Yes, hi. Thank you, Marie-Claude. So my name is Monika Wagner. I have joined INESS in 2018, specifically the Bureau of Methodologies and Ethics. So I'm supporting our institute, particularly with the approach of global value appraisal, as well as deliberation and knowledge mobilization and integration for across the different dimensions of value. So yes, thank you very much. It will be a pleasure to be here with you today.
Thank you, Monika. Annie, ton micro, Annie. There's always something that happens.
Sorry. Okay, so I'm Annie Tessier. I have a bachelor degree in occupational therapy and a master in public health, and then I did a PhD in rehabilitation. I practiced as an occupational therapist for 15 years in multiple clinical settings in Canada and in the United States. And I've been working at INESSS since its beginning. I have contributed to many projects involving mostly elderlies, people with physical or intellectual deficit, and with autism. So I'm very happy to be with you today.
Yes, and Annie is also co-responsible of INSEA methodology group with Cécile Lagarde.
Exactly. Cécile, I said too. Awesome. Yeah.
I said too. So you can start your presentation.
Thank you. So I'm going to share my screen with you. Okay, so you can see it right now. Okay, just a moment. Oh yeah, here. Okay. Are you able to see my screen? Yes? Okay. So our presentation it will be about the INESSS value framework for health and social services assessment. So we'll be presenting you. Okay, just a moment. Okay. So we will presenting you first some aspects about INESSS and our approach to evaluation and value appraisal. So first we will get into the theoretical foundation of this approach, as well as of the specific that INESSS adopted with a focus on multidimensional value appraisal, knowledge mobilization and integration, and deliberation. This will be followed by a concrete example. So the evaluation of early intensive behavioral intervention for preschool children with autism. So first, some background about INESSS. So INESSS was created by law in 2011 and it functions as an independent governmental agency linked to the Ministry of Health and Social Services in Quebec, Canada, and we serve a population of about 8.5 million people. We are a team of 275 people that is connected to healthcare and social services professionals. We have connections with patients, users, decision makers, and citizens. We have a board of directors, a scientific council, permanent deliberative committees, a user and caregiver panel, as well as 4 scientific directorates. So these directorates evaluate a variety of interventions. So we have one directorate which performs evaluation of drugs and technologies for reimbursement. Another one which evaluates healthcare interventions and appropriateness of healthcare services. We have also the directorate where Marie-Claude is the director, is the evaluation and support for improvement of interventions and clinical practices in social services and mental health, as well as our newest addition is the directorate that evaluates and supports improvement of first-line practices and community services. So our mission is to promote clinical excellence and the efficient use of resources in the health and social services sector. And we have the vision of producing a tangible impact on collective well-being by mobilizing knowledge. And our values are excellence, independence, openness, scientific rigor, transparency, integrity, and fairness. So these are the various mandates that INESS is called by law to take on. So there's a variety of activities that INESS is performing. First of all, assessing the clinical advantages of cost of technologies and other healthcare interventions, preparing recommendations, developing clinical practice guidelines. We also do service performance evaluations within the healthcare systems of Quebec. And of course, we have to keep our recommendations and practice guides up to date, distribute them and publish them, as well as help implementing our recommendations with knowledge transfer and activities. So this slide here presents a little bit of a history of INESS, focusing on our methodological evaluation of our institute. So as I said, INESS was founded in 2011, and until about 2016, our evaluations, our methodology centered around clinical efficacy and safety. Then, starting around 2017, we began to experiment or reflect on the addition of multi-criteria approaches. There were some pilot projects, as well as we reviewed our practices. We did consultations, internal as well as external, and reflected on how we can evolve our approach to have a broader perspective on value. So all these reflections led to the recognition that our final overarching aim is to create value for Quebec's population. But in order to do that, we need to base our evaluations on a coherent approach, on coherent ethical and methodological foundations. So all this work culminated finally in 2021 in the publication of our Statement of Principle and Ethical Foundations, in which we specified our approach. And the work on further evolving our methodologies continued. So in 2022-23, we established standing deliberation committees. We continue to refine our framework. Currently, we're working on integrating environmental consideration in our value appraisal framework, as well as working on equity, diversity, and inclusion strategy. So now we may ask ourselves, we take a step back and ask ourselves, why do we need a coherent ethical and methodological foundation? This comes with the realization that evaluating interventions in health and social services is not just a technical exercise, but it's a value-laden process that involves making value judgments. So when we realize that, we also realize that stakeholders may attach different importance to the different values that are at stake in an evaluation, so that they may have different views on the value of an intervention. So realizing this, how can we ensure that decisions or recommendations are fair and perceived as legitimate by stakeholders? So when we reflect on this, we go back to the seminal work of Daniels and his co-workers published at around the year 2000, who have proposed that in order to make fair, or in other words, legitimate decisions about interventions under resource constraints, we need to ensure that certain conditions are met. And these conditions, Daniels has named accountability of reasonableness, A4R conditions. And these are, first of all, a fair process, which means transparency and publicity of the work, as well as reversibility of decision or recommendations making and enforcement. But also it means that decisions, or in other words, also our recommendations as a recommendation-making body, are based on reasons that are agreed by stakeholders to be relevant to the overarching goal that is pursued by the decision. So given that our goal is to create value for our population through the health and social care system, we need to reflect on what that concretely means. One of framework that we can go back to is the one that has been developed by Berwick et al. In 2008, which was very influential, very seminal. And Berwick and his co-workers proposed that healthcare systems, and I will add also social care systems in that, because INESS, we are taking this broad approach, they can be improved through the simultaneous pursuit of three aims: improving the experience of care, improving the health of populations, and reducing healthcare costs. So which is called triple aim, patient population sustainability. What is important here is that it's the simultaneous, it's a simultaneous pursuit of all these three goals without letting one, passing one by. So that was Berwick in 2008, which is inspired a lot of work. And a little bit later on in Göttgebur and her co-workers have developed a reflective multi-criteria approach. And they proposed through their work that health and social care systems have specific ethical imperatives that are behind the concept of universal health and social care systems. And these are alleviate or prevent suffering, prioritizing those who are worst off while aiming at the greatest good for the greatest number, as well as ensuring sustainability of the health and social services system. So they also propose that there are contextual imperatives in recommendation making when it comes to improving or making recommendations to improve these systems. And this is to base our recommendation on the best evidence available. That means knowledge, to be really informed by knowledge, and to adapt recommendations to the specific context. In a paper published in Lancet in 2017, Göttgebur and her co-workers proposed combining accountability for reasonableness principles, the A4R principles, that I just presented, with multi-criteria approaches. So to ensure procedural fairness, so legitimacy, as well as that decision criteria are defined and aligned with the overarching goal of health and social care systems. So this is the conceptual background, the conceptual foundations on which we at INESS based our work to develop our statement of principle and ethical foundations and our approach. So now back to INESS. So our approach involves two domains, two elements. So one is global value appraisal, which defines 5 dimensions of value. And the other element of this approach is more procedural or operational, which defines 5 principles. Among them, notably, is knowledge mobilization and integration, as well as multidimensional deliberation. So I will get back to that after I present the global value appraisal approach. So global value appraisal states that an intervention provides value to the extent to which it improves the health and well-being of its users, contributes to a better state of health and well-being for the population as a whole, in alignment with the concern of fairness, optimizes the use of resources to support the responsible and sustainable management, fits into the organizational context of care and service delivery in a manner that contributes to strengthen the health and social services system, and fits into the context of the Quebec society in a manner that promotes its evolution towards the common good. So global value appraisal seeks to consider and balance these 5 dimensions in evaluations. And we are also aware that ethical issues may arise during evaluations, but they may arise in any of those 5 dimensions. So that's why they are integrated across the 5 dimensions of value. We are also right now in the process of integrating environmental considerations across these 5 dimensions. Now I want to present to you a little bit more in detail, going into each of these 5 dimensions, to present to you what are the value criteria. How is value defined in each one of them? So when we start with the populational dimension, we can say that a valuable intervention targets a condition or problem that has an important impact on the health or well-being of the user or others affected. Targets a condition or problem that has a high populational burden, that is not well addressed by current interventions or services, and valuable intervention is accessible to all users who may benefit from it, and addresses social determinants of health. So that will be like the ideal intervention when it comes to the populational dimension. When we come to the clinical dimension, a valuable intervention prevents the targeted condition or problem or produces desired beneficial changes of the condition. So we will look at both prevention and treatment or therapy. And it has a fewer intervention-related harmful or undesired effects on health and well-being. It produces beneficial changes in user perceived health, well-being, and or quality of life, and it empowers and respects the user, his and her values and vision for life, and provides a positive user experience. So the patient perspective on intervention outcomes and the intervention itself is very important. When we come to the organizational dimension, a valuable intervention is aligned with the mandate and scope of the health and social services system, reinforces the capacity of the system to provide appropriate high-quality care and services, and preserves and promotes the well-being of health and social services providers. In the economic dimension, available intervention optimizes the use of resources of the health and social services system, of the use of resources of the users or patients, and the use of societal resources. And when we come to the sociocultural dimension, so this is the 5th dimension in our framework, available intervention promotes the common good within Quebec society in accordance with the principles of solidarity, autonomy, and inclusion, and it aligns interests and practices with the common good. So this would be like the ideal, or these would be the criteria under which we will evaluate an intervention. So clearly, in order to operationalize this global value appraisal, we need to collect, mobilize knowledge. We need to collect knowledge and evaluate and synthesize it, as well as we need to deliberate into which extent the intervention provides value for our healthcare system. So I want to focus now on these 2 principles, operational principles. So the knowledge mobilization and integration, the objective here is to gain a clear understanding of what is known about the intervention across its relevant dimensions, as well as having really a knowledge or understanding of the limits, the uncertainties, and the ethical issues involved. So collect data and critically appraise the data that we have collected. And we do this through applying scientifically valid and rigorous methods to collect complementary data from different sources. So we are, first of all, of course, scientific literature, but we also consult patients, service users, providers, scientific and clinical experts, and also we consult clinical administrative databases as necessary. Then we analyze the quality of the data according to each type of data. And then this data is synthesized and integrated for each dimension in order to present it to the deliberative committee in a way that ensures its adequate understanding by the members, by the committee members. So when it comes to multidimensional deliberation, this is a moment when a group of individuals aiming for the common good come together to appraise and weigh the arguments regarding in what way and to what extent the intervention would or would not create value for Quebec's population. The discussions of the committee are based on the data that is mobilized by the scientific team. And the goal of deliberation at INESS is to develop rationales and orientations based on which INESS will develop its final recommendations. So now, how to ensure that the deliberative process is coherent, so from one evaluation to the other, as well as legitimate. So what we established recently, as I showed you previously, we have established permanent deliberative committees that are made up of people with diverse perspective. So our committees include citizens, clinicians, researchers, health and social care managers, and ethicists. Another feature that we try to pursue in our deliberations is that all relevant arguments are considered. So that's why we try to include the five data from the 5 dimensions of value as relevant in our deliberations. The deliberation itself, we try to foster a climate of openness and mutual respect. And what is also very important, to have a robust methodology and process for the management of conflict of interest and roles, to ensure that deliberations have a focus on maintaining a focus on the common good. So with that, I will let Annie take over to present an example.
Hi, I'm happy to present to you an example of from a project published recently about the evaluation of an intervention developed for autistic children, and it's called Early Intervention Intensive Behavioral Intervention, IB, which is based on the principle of applied behavior analysis. When the Health Ministry approached us, IB was the mainstream intervention, but they wanted to know whether it should still be considered the intervention of choice. You can switch. So as part of the evaluation, we assess the intervention from all its angles, as Monica explained, starting with the population targeted and its unmet clinical needs. We found that there was a significant increase in the number of people with autism in the last decade in Quebec. And autism affects children's development, especially social communication and behavior. The profiles of the affected children are very heterogeneous. The parents express a diversity of needs and expectations regarding the intervention and the services, and it includes the need to be equipped to support the development of their children and to be better informed about the condition, autism, and available services. Quebec has a limited service offer for children with autism, with IB having a preferred status. Unfortunately, the access to the service offered in the public service sector is limited and variable across Quebec. There are many children on the waiting list. Next. We also consider the socio-cultural context around autism and its intervention. So IB for children with autism has been developed in the 80s, and adopted widely in the beginning of the 2000s by a number of jurisdictions, including Quebec. There's a high degree of polarization around IB among parents, professionals, as well as researchers. There's a growing recognition of neurodiversity worldwide. The international trend is to put in place a wide range of services to meet the individual needs of the children and their families. So the service, they are designed to support them and not to cure them. There's that big change. In Quebec also, there's a major shift that is underway with the acknowledgement of the social movement, which recognize the neurodiversity as a strength. Next. In order to document the clinical impact of the intervention, we conducted a systematic review. We found that in the comparative studies, in the short term, IB improved adaptive functioning, expressive and receptive language, cognitive functioning, and severity of autism symptom as a whole. But the magnitude of the effect was limited to moderate. We couldn't document improvement in parent stress or satisfaction, and the level of confidence was generally low because of the quality and the quantity of studies that we found. There's also uncertainty regarding the medium and the long-term effect of the intervention, its effect on other outcomes such as quality of life or schooling, and we didn't quite know well the possible adverse effect. It's important to note that in those studies, IB was provided in the child's natural environment. The professional received a clinical supervision. The intervention was given for 13 to 35 hours a week for a period of over 1 to 3 years. We also held consultation with parents, which confirm what was already reported in the literature. That is, parents have mixed perception and experience of the effect of IB, some positive and some negative. For some parents, IB really doesn't align with their values. Another dimension that we consider is the organizational dimension. The organizational requirement to provide the intervention, its impact on the health system regarding human and material resources, such as is there enough equipment, sufficient trained staff. So we found that IB requires substantial resources. First, you need to train the people, the professional, because the intervention is quite complex. You need to analyze the need of the child, evaluate the reinforcer, setting goals, plan strategies. So it's complex. And the professional also needs supervision by a trained, certified person. And as mentioned, there's a significant demand in human resources. In Quebec, the requirement to provide that intervention is at least 20 hours per week on a one-to-one basis. So there's current challenges in the offer in Quebec. So the service delivery is quite variable across Quebec. There's some region that actually doesn't provide the service because it's too demanding. There's a high staff turnover, and as mentioned, training issues. There's a challenge also in the collaboration between the healthcare sectors, but with the schools and the daycares. So many people, partners, stakeholder involved. Next, there's a question. Should I take it at the end, or because I don't see the question now? I'll take.
Maybe you can take it at the end, Annie.
Okay, perfect. So the last dimension to be considered is the evaluation of the cost. It can be a formal cost utility, cost effectiveness analysis, but in some situations, we do simply document the financial burden of the evaluation. But for IB, we were lucky to have a solid study from the UK on which we were able to build our evaluation. That cost utility in UK suggested that IB is not cost effective when compared to other intervention, and that is using the IKEA cost effectiveness threshold. We did an adaptation of their model to the context of Quebec, and it led to similar results. Although IB may procure potential savings in school, health, and social service utilization, the saving seems to be less than the cost of providing the intervention compared to other interventions. We did 2 scenarios around whether the improvement was maintained in time or not. So the model estimate varies significantly depending on whether the effectiveness was maintained over time. And these results should be interpreted with caution because there's limited local data, and also it's limited the ability to transfer the result of one study to another context. Okay. The final step before coming to developing the recommendation is the deliberation with the committee. And as Monica explained, the process is that we present the data from the 5 dimensions to the committee. The data is what I just showed you. And we deliberate, we ask the committee to share their perspective on the aspects that are important according to them. So I'm going to tell you what the committee said, and you can see through that the 5 dimensions or the argument around the 5 dimensions are there. Hopefully you will see it. So the committee said, in light of the recognition of neurodiversity and the fact that the needs of the children with autism and their family are heterogeneous, their needs should be met with diverse evidence-based intervention. Although published data seems to favor IB, the level of confidence is low. Its real-world efficacy and long-term effect are uncertain, and the transferability to the Quebec context is limited. Another thing they said is offering IB requires substantial resources, which has to be considered in light of accessibility and equity issues, not only for the children with autism, but also for the other who has other developmental disorders. The profiles and needs of children and their family vary considerably. It is therefore necessary to adapt the intervention. Nevertheless, it's the opinion of the committee that the condition under which IB should be offered need to be specified. They also thought that the evidence available, the optimal intensity of the intervention was insufficient, so therefore we could not make a recommendation regarding it. And finally, it's very important for them, according to them, to involve parents in decision-making and equip them. So finally, INESSS make recommendation that reflects the deliberation and considering all the data that we collected and the perspective of the committee. INESSS recommendations were as follows. Provide service based on an array of evidence-based approaches and intervention, including IB. Because I don't know if you remember, but the initial question was whether we should still consider IB as the first choice. And our final conclusion was there's not enough evidence to say don't do it. So we're not recommending to withdraw the intervention. We say maintain it, but diversify because there seem to be other things that works as well. When IB is provided, this should be done in the children's natural environment, such as home or daycare, by a IB-trained professional under the supervision of a clinical supervisor. Adapt the modalities of the intervention, such as the intensity, according to the need and the response of the child. Involve and equip parents as soon as possible to support the child's development, and train professionals so that they have better understanding of autism, neurodiversity, and child decision-making process. That's it for me.
Thank you very much, Annie. So, so just to wrap up, so in summary, so we understand that evaluating interventions in health and social services and developing recommendations means making judgments on their value. So to live up to our vision of improving the collective well-being of the population, so I'll just go back at one of the beginning slides where I presented you our vision. By mobilizing knowledge across the diversity of interventions in health and social services, and you just had a very good example about AIB. So we need to pursue procedural fairness, so the accountability for reasonableness, such as transparency, publicity, but also it means rigor and methodological rigor in our work and all this, but also having a consistent and well-defined value framework that is aligned with the overarching goal of our health and social services system. So evaluating intervention requires knowledge about the impact across the different dimensions of value that are relevant to this. We're trying the 5 dimensions. We not always assess all 5 dimensions, but we consider that at the beginning of our evaluation, whether all 5 of them are relevant and we're going to be addressed. So we need knowledge. So and this knowledge is mobilized through complementary, scientifically valid and rigorous methods. So systematic literature review, as Annie presented, but also consultations of stakeholders. In this case, of course, parents were very important stakeholders, but also the service providers and others that we consulted, and also to contextualize, to understand how this intervention, EIB, will be applied in our context or is used in our context in Quebec. So that was very important. It was a very important element of this evaluation. And finally, when it comes to deliberation, the legitimacy of deliberation rests on the inclusion of diverse perspective in the committee. We have expert methodologists, but also ethicists and public representatives of the public. But diverse perspectives, but trying together, aiming towards the common good. And as well as considering all relevant arguments when evaluating this intervention, having really this broad perspective on the intervention as Annie presented in this case. And you saw the variety of arguments that were taken into account by the committee members. So now we are very happy to respond to your questions.
Thank you so much, Monica.